Hello everyone, and thanks for joining us today. My name is Lindsay Klassen, and I'm here with Natasha Campbell. We are co-chairs of Preventing Overdose Waterloo Wellington, which is a grassroots organization here in Waterloo, Wellington area, dedicated to preventing death and harm related to overdose. So today we're going to be talking about opioid-specific overdose. We're going to give you a little bit of information about other types of overdose as well, but we are focusing in on opioid overdoses for the Eyes Wide Open webinar series. I can get my slides to go. Okay, so to start with, here's what we're going to cover today. We're going to talk a little bit about what an opioid overdose is, who's at risk for an opioid overdose, how to recognize an opioid overdose, myths and facts, and how to respond to an opioid overdose. We're going to ask you to hold your questions until the end, at which time we'll do our best to respond to them.
So in the next few slides, I'm going to cover what is an opioid overdose, and more specifically I'm going to go into what the central nervous system is and the effects on it from psychoactive drugs, depressants as a whole category, as well as stimulants and hallucinogens. Define overdose, and talk about types of overdoses. So the central nervous system, this maintains our consciousness, memory, and emotion, and it also sends signals from the brain to the rest of the body to control breath, movement, and balance, as well as our senses, hearing, sight, smell, taste, and touch. So psychoactive drugs have three main effects on our central nervous system, which is a depressant effect, a stimulant effect, or a hallucinogenic effect. Depressants cause the central nervous system to slow down, so breathing and heartbeat slow down. Some people may take depressants for a sense of relaxation, pain relief, or just a general lowering of their inhibitions. So some examples of depressants are opiate drugs. So this is a big category on its own. This includes heroin, morphine, codeine, methadone, Dilaudid, OxyContin. Alcohol is also a depressant. Benzodiazepines or benzos, which is anything in the PAM family, so anything that is like a Valium. Cannabis and inhalants. Uppers or stimulants cause the central nervous system to speed up, so it's also causing the breathing and heartbeat to speed up. People may take stimulants so that they can feel increased energy and alertness, increased confidence, and maybe they just want to stay awake. Example of uppers include amphetamines and methamphetamines, cocaine, ecstasy, nicotine, and even caffeine. Hallucinogens or psychedelics. These drugs distort what people hear, think, and see, and people take hallucinogens so that they can distort what they're hearing, seeing, thinking, feeling. Examples of hallucinogens include magic mushrooms, LSD, ketamine, and cannabis. And cannabis is is a drug that does fit into two types of categories, so it is a depressant, but it also has hallucinogenic effect. So overdose is the use of a drug or drugs in an amount or way that causes acute, harmful mental or physical effects. Overdose may produce short-lived or lasting effects and can sometimes be fatal. So we have three types of overdose here. A depressant overdose slows the central nervous system down to the point where several systems may stop working, and this is caused from taking a depressant type of drug. The stimulant overdose is speeding the central nervous system up to the point of overworking certain functions leading to failure, and this is caused from taking a stimulant drug. And a toxic overdose is organ damage or failure from taking an excessive amount of drug. So this can happen over years. Long period of time. Yeah. And today we'll be focusing on opiate overdoses, which fall into the depressant category. So after an overdose, there are other serious, sometimes permanent health problems that a person can have to deal with. So brain damage due to lack of oxygen, maybe from having a seizure or stroke or heart attack. Lung damage or pneumonia from fluid entering the lungs during a period of unconsciousness. Muscle damage due to a limb trapped under the body during a long period of unconsciousness, which could also result in limb amputation. Other serious complications can include paralysis, kidney failure, broken bones, burns from exposure to heaters or cigarettes, and physical assaults.
Okay, so now that we've got a pretty good idea of what an overdose is and the effects on the central nervous system, let's talk a little bit about who's at risk for an opioid overdose. One key thing to remember is that overdose doesn't discriminate. There's certainly no relevance to income or housing stability or gender. Overdose just doesn't discriminate. Anyone who's using a substance in a way that causes harm has the risk of an overdose. However, there are some key factors and patterns of use that have an increased risk. So we're going to talk through those a little bit. We're going to start with some demographics, some prescribing patterns, and then some patterns of use, including mixing drugs, that pose key risk factors for an overdose. So locally and across Ontario, 2007 data is pointing to accidental overdoses as the third leading cause of unintentional death after motor vehicle collisions and falls. Recently, we've seen some coroner data that's indicating that overdose as a cause of death has actually surpassed motor vehicle collisions by as much as double. So these statistics may be a little bit outdated. However, a BC review of coroner data from 2006 to 2011 allowed them to pull together a bit of a profile of risk factors for overdose-related death. There's some interesting points in here to note. So most individuals who died as a result of an overdose, it was an accidental overdose. So 86% of overdoses are accidental versus suicide. 87% occur in persons under the age of 60. Most individuals who die as a result of an overdose have a documented source of chronic pain, and almost half have a documented comorbid mental health diagnosis. 93% of overdoses are the result of taking at least one other non-opioid class of medications. And there's some distinct risk factors around the use of benzodiazepines, which also fit into the depressant category. Most overdoses are not the result of multi-doctoring, so we can put aside that stereotype. Almost all are taking medications prescribed by a single doctor or clinic, and overdoses happen everywhere. There seems to be no geographic or population density correlation. We expect that most of these demographics would be translatable to here in Ontario and probably across Canada as well. So in 2009, in an Ontario study in the Canadian Medical Association Journal, they linked the 850% rise in oxycodone prescribing with a quintupling in oxycodone-related fatalities. Not terribly surprising. The more oxycodone being prescribed, the more depressants and opiates being prescribed, the higher the rate of overdose death. Among the highlights of this particular study, they noted that 66.4% of people who died as a result of an overdose had visited a physician in the month before death, and 56% had filled a prescription for an opioid in the month before death. So what they're finding is that many people who are dying as a result of an overdose are actively engaging in the care of a physician and pharmacist. They noted that approximately 50,000 Ontarians are addicted to opioids, and many more are dependent. And it was noted that Canada has the highest per capita rates of opioid consumption in the world, having surpassed the States just recently. And in 2009, there was a CAMH study done that indicated that more youth in Waterloo Wellington had consumed opioids for non-medicinal purposes than tobacco, the highest rate in Ontario, and that most of them got it from home. So when we're talking about being at risk for an opioid-related overdose, the numbers are quite staggering, and the reality is that many, many people are at risk.